Okay, I have here esophageal cancer. The way to look at this is really that the depth is what drives a lot of the management, including a nodal status also has a very heavy prognostic factor. So you look here, you have the lumen, intraluminal of the esophagus, you have the mucosal layer here, all right, and then you have the beginning of the submucosa. Of the mucus layer, you have the epithelium, you then have a basement membrane, the lamina propria, and the muscularis mucosa. All of this comprises the mucosal layer rather, okay? Next you then have the submucosa, and I'm going to draw these as lymph nodes to remind me that the submucosa has a very rich and dense lymphatic system. Next you have, I'm going to draw these going transversely to represent the circular layers, muscular layers, and then longitudinally, in the length of the esophagus, you have the longitudinal muscle fibers. Both of these together, both these together comprise the muscularis propria layer, okay? And then just illustrating here, this is a connective tissue-like structure, which is the adventitia. This is not like serosa. It has an epithelial layer, but no squamous cells or nothing as robust as a serosa, which does contain thick layers of squamous cells and does produce fluid. So we look at these, and then I'll draw the lymphatic system here draining down, okay? When we're looking at tumor depth, if we're penetrating into the mucosa, this is a T1A lesion. If it reaches the submucosa, this is a T1B lesion. If it reaches into the muscularis propria, it's a T2 lesion. And if it reaches into the adventitia, it's a T3 lesion. And then if you have other structures such as let's draw the pericardium here, you can have diaphragm, let's see what else. You can have pleura. All of these are going to be, this is a T4A lesion. These are technically resectable, but they are beyond the esophagus. And structures such as the aorta and the trachea and the vertebrae, these are all non-resectable structures. Cannot resect those. Okay. Then looking at our nodal status, you got N1, 2, and 3. N1 is 1 to 2 lymph nodes, N2 is 3 to 6, and N3 is greater than 7. Obviously metastasis is M1. And then you have also grading is important when it comes to decision making. Grade 1 is going to have more than 90% glandular structures seen on histology, which is more representative of the normal histiotype. These are well differentiated, okay? Then you're gonna have a grade 2 is still gonna have greater than 50%, but definitely not 90. And this is gonna be moderately differentiated. And then grade 3 is you're gonna have less than 50% glandular formation. I'll just do quote this again. And this is considered poorly, okay? And then, so let's stage this, okay? So you got your staging. You got stage 1. You're gonna have your T1 lesions or your N0, M0. So you're gonna have T1A and your T1B lesions, okay? T1A, if you remember, is into the mucosa. T1B is into the submucosa. This one, let me get a different pen. The T1B changes management, okay? So T1A, you can usually get away with EMR and other less invasive procedures. T1B, you need esophagectomy. Some texts talk about having the difference when you have high grade lesions, or high risk, sorry. So high risk factors is going to be tumors greater than 3 centimeters, positive lymphovascular invasion, and a grade 3 lesion. Okay, so these also play into here, but this is a very basic, watered down version of it. Stage 2 is going to be your less than T3 or less than penetration into the adventitia. Still your N0, N0. So this is in the adventitia. Okay, or your T2 lesions, or your N1. So we'll mark these as significant levels here. And this is pretty much practically anything greater than 1 lymph node. Okay. Now I'm going to include stage 3 in here because it's a similar management. So grade 3 is anything less than T4. I'm going to say T4A. Okay, T4 and A and less, and 3 and M0, so no metastasis yet. That this is reminding me that it is technically into an adjacent organ. It is locally advanced. Okay. These ones are going to undergo neoadjuvant chemotherapy, chemorads actually, neoadjuvant chemoradiation, and then you're going to restage them and hopefully be able to do an esophagectomy. And downsizing. And then our stage 4 disease is our M0 or M1, so our METs, or your T4B lesions, the non-resectable. Okay, and what the treatment for this is going to be definitive chemoradiation, and you'd also consider palliative treatments in these. Palliative meaning you'd have your chemoradiation, your photodynamic therapy, also laser, esophageal stenting. Stenting. Of note, though, a huge majority of these people are not alive 6 months later when they're needing a stent for obstructive reasons. Also, feed them, find ways to feed them, gastric or jejunal tube. And then also you can consider a palliative resection. When we're doing our chemotherapy, typically it is the 5-fluorouracil and a taxane. Okay, and when these are indicated is for your T2 lesions without lymph nodes, but they do have high risk features as stated over here. Okay, that's when you do your neoadjuvant. So this is neoadjuvant. Okay, and when you do adjuvant therapy is, I mean, you can use it for any of these, but a key point here is in squamous cell carcinoma, if it's already R0, then you don't need, you do not need adjuvant chemotherapy, regardless of their nodal status. Don't need adjuvant chemotherapy, regardless of nodal status. Something important with the chemotherapy, the reason why it has such an early use of chemotherapy is because of the cross trial. Okay, this they were using the carboplatin and paclitaxel, and they found improved 5-year survival for T2 lesions. So T2 lesions improved 5-year survival for T2 lesions. It was 47% versus a 34%, so significant there. And then just a word about Barrett's real quick. Barrett's esophagus. So this is, if you remember, metaplasia from your squamous to columnar cell type. So if you have metaplasia but you don't have dysplasia, then technically non-complicated Barrett's. Okay, so your surveillance for these are going to be EGD every 3 to 5 years, okay, with biopsy. If you have a low-grade dysplasia, okay, your surveillance period is going to be Q6 months, or you can just go straight to EMR, okay? If you have high-grade dysplasia, then we're going to up the game, and we're going to do EMR versus go for esophagectomy. Esophagectomy used to be the answer, but with the advancement of endoscopic technique, esophagectomy has been found to be effective and safe. However, something to remember when we are treating these patients with Barrett's, or rather with patients that have reflux, and we do a fundoplication, they still need the surveillance. Even though we expect the exposure to the mucosa to improve in the esophagus because of the restoration of the GE junction, they still need surveillance. I spelled that wrong, but it will. Okay, that's it.